Good afternoon. This is Dr. Kachikian from the Black Hills Regional Eye Institute, and today we have a case of a Morgagnian cataract. Now, this may look like any other white cataract that you may see, but when I was examining this patient in clinic, it was clear that this is what they call a Morgagnian cataract. A Morgagnian cataract is a cataract where the peripheral cortex has completely liquefied, but the central nuclear material is extremely dense. So you can have some white cataracts where there's liquefied peripheral cortex and the central lens is somewhat soft, but then you can have cases where their peripheral cortex is completely liquefied and the central nucleus, not only is it extremely dense, but it has kind of fallen through the liquid and is sitting kind of towards the bottom of the eye, at least when the patient is standing upright or sitting upright. What you'll see here is that we are going to inject some trypan blue into the anterior chamber to stain the capsule. And I really like to get a good capsular stain in this case, because one thing I'm concerned about is what they call the Argentinian flag sign, where you make an opening in the capsule and then that capsule opening extends kind of north and south, so to speak, and then it looks like a central kind of white break in the capsule, and with the blue on either side, looks kind of like an Argentinian flag. And so I really want to make sure the anterior capsule is stained very well, so I use the trypan blue twice. I normally will put the trypan blue in usually under viscoelastic, because I think it's gentler on the cornea when the trypan goes in under viscoelastic. But because I want a more uniform, dense stain, I put the trypan in under air and VSS in this case. So we'll get the capsule fairly well stained so we can initiate our capsulorhexis. The very next step here is that we are going to inject some viscoelastic. And we do want a really good viscoelastic fill. We don't want the anterior chamber overfilled, but we want it filled enough so that when we do puncture the anterior capsule, the pressure gradient isn't such that the fluid inside wants to squirt out or rupture out. You kind of want the pressure gradient between the inside of the capsule and the outside of the capsule to be fairly even. Now when I make my incision here, I try and make a very square incision, and then to initiate the capsulorhexis, I will usually use, in this case when there's a liquefied cortex, a 27 gauge needle. So we put a little more viscoelastic in the eye, and then I take the 27 gauge needle and I make sure the plunger is mobile, and I enter the eye, and I'm going to enter the capsule bevel down and aspirate immediately. And so you can see the capsule opened up a little bit, and as we aspirate here, you will see that that liquefied peripheral cortex goes into the syringe, and you'll start to see the red reflex appear at the periphery of the lens, and there it is. So what you've got now is much of that liquefied peripheral cortex removed. Not all of it, but a lot of it, enough to reduce the pressure gradient. And then you've got the dense central nucleus that remains to be removed. And so we'll put a little more viscoelastic in, and then we will begin our capsulorhexis. We want to make sure all of that peripheral liquid cortex is out. One thing that you will find is that sometimes the liquefied cortex is in pockets. Not necessarily in this case where it's all liquefied, but in some cases where there is liquefied cortex and a pressure gradient, you will find that there are pockets of liquid cortex. And as you do your capsulorhexis and kind of bring it around, those pockets can open up and cause the capsulorhexis to extend. So you want to try and make sure that there's always good viscoelastic fill, and that you're careful as you do the capsulorhexis. And so we will continue our capsulorhexis after puncturing the anterior capsular bag. In this case, we'll try and do a reasonably large capsulorhexis because we want plenty of working room. It's a little more difficult in this case, however, because the bag is so flimsy. It's not filled with a plump lens anymore. Most of the bulk of the peripheral part of the lens has been aspirated already. And So we'll do our capsular excess, kind of gently bring it around, and then what we will have is a kind of dense central nucleus, but without any peripheral cortex to hold the capsular bag back. And as the case proceeds, you will see that the capsular bag, because it's not being held open by any cortical material at all, wants to come forward. So we'll take some viscoelastic and we inject it around the lens, try and create kind of a little sandwich so that the nuclear material has viscoelastic both anterior to it and posterior to it, so the capsular bag doesn't want to come to the phaco tip. You can see how much peripheral cortex was aspirated because the whole nucleus of the lens is shifted to the left side. That's not because there's any zonular loss in this case. It's just because the capsular bag is very large. We've removed a large portion of the fluid or liquid cortex, and now the lens is shifting in its position. Now we'll take our phaco handpiece and put it in the eye. I always initiate on a divide and conquer or chop mode, not a sculpt mode. And the reason I do that is to clear the phaco handpiece tip, especially when there's a lot of viscoelastic in the eye. So we're bringing that central nucleus up and we're going to chop it. Now you may have seen in some of the other videos that I have done, chopping these white cataracts is sometimes easier said than done, but the key is patience. And you just gently kind of go around, carousel so to speak, and break off little pieces of this white cataract. And when there is a large piece of nucleus that you're working with, sometimes it's a little bit safer because you've got this whole piece of nucleus holding back the capsular bag while you remove much smaller pieces. And so in the initial portion of the case, as we are doing our chops, it's not necessarily easy. As you can see, it can be difficult to propagate these chops, but you're also not worried about the capsular bag jumping up at you because the large heminucleus is holding it back. As you remove pieces of nucleus, all of a sudden there's nothing holding the capsule back, and that's when I start using the viscoelastic more and more to keep the capsule back. And so again, we're just kind of gently chopping this lens into pieces here. I again try and be very patient in doing that because eventually the pieces will start to kind of chip away. So we've just gotten little by little some peripheral pieces of nucleus out of the eye. And you can see how dense the central lens is. The lens is kind of sitting vertically right now. And the reason it can do that safely is because the capsular bag is very large. It was expanded by that liquified cortex. It was stretched out. And so it's very large. And so now that the cortex has been removed, the nucleus can actually sit vertically fairly easily and still be almost completely in the capsular bag. So we will just kind of continue chopping here. I do kind of use a little sawing motion sometimes to get through some of those leathery attachments. And so I will use the second instrument and kind of rub it against the phaco tip with the nucleus in between to try and break some of those adhesions. So now we've got, maybe a third of the nucleus out. And we're going to put a little more viscoelastic into the eye. And what that's going to do is visco-dispersive. We want to keep it behind the lens so that the capsular bag doesn't come forward. Again, that's probably the most important thing at this point, keeping that capsular bag back so that I can use my phaco settings to break up the lens material and not have to worry about aspirating anything I shouldn't. So we will gradually break this lens up into smaller and smaller pieces. And what we will find here is that as the bulk of the lens material is removed, the capsular bag appears to become flimsier and flimsier. And so you'll see some wrinkles to it as it attempts to come forward. And so that's how I know that we want to put in more viscoelastic. And there were a couple of times during this case that I thought there was a rupture in the capsular bag because I was using so much viscoelastic to inflate it and to keep it from coming forward. But fortunately that did not happen, and we were able to keep the capsule bag and get through the case safely. But that's a lot of viscoelastic going posteriorly there. And so I really was thinking to myself, boy, is this just a really dilated capsule, or is there actually a tear in the capsular bag that I haven't identified? So we'll just keep going here, working on this last piece of nucleus. And again, this is where you want to be really careful because you've got high flow in the eye, you've got fewer and fewer nuclear pieces. You want to keep your second instrument as posterior as possible, and don't be shy about using viscoelastic. Same thing again here. I can see those wrinkles in the posterior capsule, and so I am going to reinflate with viscoelastic. Viscoelastic is way easier to deal with than vitreous, and so you want to use as much viscoelastic as you need to keep the vitreous in the eye. So we will gently work our way through this. Depending on how much nucleus is left, sometimes I will switch over to IA, and a little bit later on in this case I do that to get the last piece or two of dense material out. It's kind of a slower method, but it's also a safer method when you don't want to have the capsule kind of flopping behind you there. Nobody wants the capsule waving at them. So we'll get this last piece of lens out and then see if we want to go for that one just across the eye there gently. Notice I'm keeping that second instrument fairly far back. There you go. And that piece is actually much bigger than I thought it was, just looking at the video. So we will phaco that piece. And then you'll notice there's one final kind of medium-sized piece over by the incision, and I find those are particularly difficult to get at. You have to use your second instrument, and given the appearance of this capsule, I think I elect to go and IA that piece. When you're using the IA handpiece, what happens is that the port or the opening isn't sharp, and you can point it vertically, unlike with the phaco handpiece. And so I'll try and move this last piece with the BSS cannula, and then we'll go in with the IA. And that's kind of a big piece to IA, but I had gotten this far and I really didn't want to take any chances. And so we'll put a little more viscoelastic in because you can see all the wrinkles in the capsular bag there. There you go, and it looks like it could be torn, but it's not. That's just a lot of viscoelastic going in. But there are no holes. And so what we'll do here is we'll go back in with that IA handpiece, and we will use the second instrument to kind of force the last piece of or two of nucleus into the IA. And we'll do that just gently. The opening or the port on the IA handpiece is really small, so viscoelastic doesn't readily come in, especially when you're using dispersive viscoelastic. So we get that last piece, and then this is a little bit of a bigger piece over to the right. But it is worth taking your time and using the IA handpiece to get this in safely. Notice that I move also over to a real peripheral part of the eye, and the reason I do that is because I can use the iris and the anterior capsule as a little bit of a scaffolding or protection to prevent the flow of the handpiece from pulling in the central capsular bag. So moving over to the periphery in certain cases to either phaco or IA can sometimes be helpful because it changes the flow of the fluid inside the eye. And this is going nicely. It's a little slow. It's nobody's preferred technique, but it's very safe. Okay, so we get that last piece of lens in there and come out. Now, one thing to consider doing is once this last piece of lens goes into the IA and it's kind of being stubborn, is to reinflate the capsular bag right then and there with Pro-Visc or viscoelastic so that the capsule doesn't come forward. I didn't do that in this case, but looking at the video, that would have been helpful. So now we'll put some Pro-Visc in, and we'll use that to push the capsular bag back as much as possible. And we've got a nice round capsular excess and intact capsular bag. And we can get ready to inject our lens. In this case, because the capsular bag was so flimsy, I elected to use a capsular tension ring. And when I put the capsular tension ring in, usually I'll use a Sinskey hook to hook kind of the leading edge so that it doesn't push initially up against the capsule. In the first area of the capsular tension ring that contacts the capsule is a really broad and blunt piece. Okay, sometimes the capsular tension ring can kind of go up the arm of the Sinskey, but that's usually not too much of a problem. And so you get that in, and you'll knock that first loop kind of underneath, and then the second one. And you get your capsular tension ring in position, and that one in very nicely. It looks like it's a little bit overlap in the corner there, but that's okay. And then we will inject our lens. A little bit of anterior capsular polishing as well, just to prevent any phimosis. Kind of have a habit of doing this in almost every case because I've been doing it for so long. I did elect to use a one-piece lens because I didn't actually notice any phacodenesis when I was doing the surgery. It was more just kind of a large and loose posterior capsular bag. That's the reason I put in the capsular tension ring. And so we'll get our lens into position and then do some gentle IA to get the Pro-Visc out. And do be careful when I'm going behind the lens because that lens was so flimsy it can jump up pretty easily into the IA port opening. So be careful of that and just get out what you need to from behind the lens, and then you'll get out all the Pro-Visc and Viscoat from the anterior chamber. I did put a lot of viscoelastic in the eye, and so I think it's almost impossible to get it all out and be sure that you're not going to have a pressure spike or pressure issue. So in cases like this where they're more difficult and I use a lot of viscoelastic, I always will give the patient either a topical a pressure drop or Diamox postoperatively, either one immediately postoperatively and one before bed to ensure that the pressure doesn't spike. But this was a great case of a kind of Morgagnian cataract where we were able to remove the liquid cortex and then remove the central nucleus and take our time and be patient and get things done safely. All right. Hopefully that was helpful to you, and you folks have a great day. If you'd like to see more of these videos, please check out my YouTube channel and Facebook page. There are quite a few more videos on there, along with a See Better, Be Better podcast with some of my partners covering topics that are important to ophthalmology. Bye now.